Good morning, everybody. Thank you for joining us for this webinar, which is part of our series of presentations being delivered on applying evidence in practice as part of the Comorbidity Project, which is funded by the Australian Government Department of Health. My name is Christina Morell. I am a Senior Research Fellow and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. And along with Erin Madden, who is a Project Officer on the Comorbidity Project, I have the very great pleasure of facilitating this webinar today, which is being presented by Esther Toomey, Kate Hocknull, and Dylan Clay. Before we start, I would like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting, and of course recognise that we are meeting across Australia today. The traditional owners of the lands on which I'm on are the Gadigal and Wongal peoples of the Eora Nation, but I'd also like to pay my respects to other traditional owners of the lands across Australia for everybody else who is here. I'd also like to recognise and acknowledge the many people with lived experience of mental illness and substance use, as well as their families and carers, many of whom have generally contributed to the development of the comorbidity guidelines and our other resources. If you've been to one of our webinars before, you would have heard my spiel about Zoom, so feel free to zone out for a minute or two and rejoin us in a few slides. But everybody here is probably very familiar with our Zoom by now, but just to go over a couple of things before we get started. Just to let you know whether you're attending live or watching the recording, you're in listen-only mode, so that means that we can't see or hear you. Just wanted to draw your attention to the Q&A and chat buttons on your screen. Feel free to click on the Q&A button and type in any questions that you have for our presenters at any time during the presentation today. We will have some time to go through as many of those questions as we can at the end. If you have any comments or anything that is not for Esther, Kate, or Dylan, please use the chat. If you have any technical issues during the webinar today, you can contact Zoom support, or you can access the recording of the webinar, which we will be making available, as well as the PDF handouts of the slides from today. They'll both be able to be downloaded from the link that's on the screen there. If you find Zoom chat distracting, you can have a play around with the settings on the end of your, on your end to disable what messages you see. And to do this, you'll need to go to the Zoom desktop app if you have it installed. Click on the settings wheel in the top right-hand corner of your screen, and then select chat on the navigation menu. You should be able to have a play around with what messages you see by changing push notifications or even your do not disturb signs or times, but it can be a little bit fiddly. So the Zoom link to do that is on screen, and Erin will also put that in the chat. You can have a play around with that later. So to get us started, today's webinar is focused on how services are providing care for people with co-occurring mental health and alcohol and other drug needs. And I will hand over to Esther, Kate, and Dylan to get us started in a minute. But just before I do, I wanted to mention that we are continuing to plan for additional webinars over the next few months. And you can find out more and also register for these at our website. The link to do that is on screen there. And thank you very much for people who have been coming along to our series so far, and either live or watching the recordings later, and also sending us suggestions for future webinars. We do ask for these, so please let us know if you have any suggestions of topics you'd like to see as part of this series, and we'll see what we can do. And now it's my very great pleasure to hand over and stop talking first of all, and hand over and introduce to our presenters for today, Esther Toomey, Kate Hocknull, and Dylan Clay. Esther is Drug Health Promotions Officer at Central and Eastern Sydney PHN, or CESPN. Esther collaborates with drug and alcohol treatment services to support flexible and coordinated responses to the holistic health needs of community members experiencing harmful drug and alcohol use. Kate Hocknull is a clinical nurse consultant currently working at the Uniting Medically Supervised Injecting Centre in the role of mental health nurse coordinator. And Dylan Clay is a program manager for the Speak Out Dual Diagnosis program at Weave Youth and Community Services. I'm so very grateful that Esther, Kate, and Dylan could be here today and share their wealth of knowledge and expertise. So I will hand over to them to get us started. Thanks, guys.
Hi, I'm Esther Toomey, Drug Health Program Officer at Central and Eastern Sydney PHN, or CESPN for short. I'm really excited to be a part of this presentation today, discussing how services are providing care for people with co-occurring mental health and alcohol and other drug needs. Before I begin, I'd like to acknowledge the Aboriginal and Torres Strait Islander peoples of this nation as the traditional custodians and sovereign people of the land across which we work, which for me today is Gadigal land. I recognise their continuing connection to land, water and community, and I'd like to pay respect to elders past, present and emerging, and also extend that respect to Aboriginal people joining this webinar today. So, who is CESPN? Well, to give you some background, primary health networks, or PHNs, were established to strengthen primary care, work towards integration across sectors, and commission health services to meet the needs of the local community. So I'm based in Sydney, working across the central and eastern region, but PHNs are national and there are 31 across the country. So our funded or commissioned services include a portfolio across mental health and suicide prevention, alcohol and other drugs, Aboriginal health and wellbeing, after hours, as well as population health services. As a PHN, we are in a really fortunate position to be able to work so closely with a range of alcohol and other drug, as well as mental health services in our region. Through our annual needs assessment, CESPN identified people who experience co-occurring mental health and drug and alcohol support needs as a priority population, with unfortunately low levels of service provision. So to inform how best to address this need, a few years ago we funded the Centre of Research Excellence in Mental Health and Substance Use, CREMS, now known as the Matilda Centre, to undertake a scoping exercise to evaluate the current practices and support needs of healthcare providers in the region who work with clients with co-occurring mental health and alcohol and other drug issues. So the scoping exercise was undertaken to improve understanding of these issues from multiple perspectives and provide recommendations for workforce development and capacity building. There were 8 recommendations that arose from the report, which included the provision of education and training opportunities, improved access to up-to-date evidence-based information on mental health and AOD use, the provision and ongoing support of clinical supervision for healthcare providers, the development and maintenance of an online service directory, the development and pilot testing of innovative services and the enhancement of existing services to address areas of unmet need, the development and pilot testing of an accreditation program for peer workers, and the provision of specialist training scholarships and subsidised placements in AOD and mental health services. And finally, the development and pilot testing of a model of coordinated care. So there are some really great recommendations, but how do we tackle it? Well, what we did was CESPN then decided to convene a region-wide mental health and alcohol and other drugs working party. And the party had a range of experience and expertise, and together we developed strategies to address the recommendations with the ultimate aim of improving the capacity of healthcare providers to identify, intervene, and provide appropriate referral and coordinated care for people with co-occurring substance use and mental health conditions. So the strategies that were developed can be found in the Mental Health and Alcohol and Other Drugs Action Plan, which is linked here in this presentation, but also on our website if you wish to take a deeper dive. You'll also be able to see on the right of your screen a poster summary of some of the strategies identified. Now, there are some big ticket strategies here, and we acknowledge that not all have been implemented. However, what I'm going to do is run through some of the strategies that have been. Firstly, one of our strategies looked at our commissioning process and the contracts that we develop with service providers. You know, at a higher level, when we go about commissioning or recommissioning a service, there's always a contract, of course. So this is a really great place to start. We've embedded a clause within mental health and alcohol and other drugs contracts that specifies the need for funded staff to engage with relevant training, resources and professional development opportunities to ensure that they can effectively support people from a range of priority populations. with specific inclusion of people with co-occurring mental health and drug and alcohol needs. In these contracts, we've referenced the comorbidity guidelines training for staff to access and engage with. Similarly, embedded into contracts is the requirement for funded staff to receive clinical supervision. This ensures that at a practical level, staff can reflect on their practice, compliance needs, and any challenges that have come up, discuss options and opportunities for providing care, considering holistic approaches, for example. Ongoing clinical supervision, like most of you would know, can really allow staff to put into practice what they may have learned through training, with skills strengthened, developed, sustained, and built upon. Some other strategies we've implemented include capacity building activities for the local workforce. So South Eastern Sydney Local Health District will be trialling an approach to build the capacity of nurses in their mental health settings to effectively support clients with co-occurring AOD use. This will involve the development of a train the trainer package to be rolled out for nurses, evaluating impact on knowledge and skills, confidence, and responses to AOD use via an audit of practice and documentation. And the Train the Trainer will be developed in consultation with other New South Wales LHDs, and albeit these health settings are diverse, discussions with other LHDs will help to identify work occurring in this space across the region to ensure information is shared. Additionally, the peak body for community managed mental health organisations in New South Wales, the Mental Health Coordinating Council, or MHCC for short, are offering a new online training course to support the development of workers' knowledge and skills to support people with co-occurring mental health issues and substance use. So this course is a nationally accredited competency that sits within community services qualifications. CESPN actually recently funded 20 placements for the course, and it was piloted in November for staff working in the region. And there was some really great engagement across the board, and this will be an ongoing offering from the MHCC. At a PHN level, we've also run training for the local workforce in the region. And just last year, we ran some double whammy mental health and AOD training, which was facilitated by a training provider called CCWT. And similarly, there was some really great uptake and engagement in that training. Also identified as a recommendation within the scoping report was the recommendation for the distribution and availability of up-to-date evidence-based information for the workforce. And in response to this, CESPN have developed a designated web page on our website, which includes such information like including the comorbidity guidelines, as well as other relevant training resources, links, webinars. And this information is being collated in collaboration with a range of stakeholders. And I encourage you to take a look if you're interested. So those were really some strategies that we've currently actioned. There are some more identified in our action plan, and if you wish, you're more than welcome to take a look at the action plan for more detail on the strategies discussed here, as well as other strategies not yet mentioned. Now, I wanted to share with you some of the ways our local mental health and AOD services, which CESPN fund, are supporting clients with co-occurring needs. So ACON Substance Support Service provides free short-term person-centered alcohol and other drug counselling for people of diverse gender and sexuality, their partners, family and friends. And the service acknowledges that co-occurring mental health and AOD needs are the norm. It's not the exception. Starting at initial discussions, ACON, like many other services, utilise outcome measures such as the K10 or the Kessler Psychological Distress Measure, the Quality of Life Measure, as well as the Severity of Dependence Measure or SDS, which can start a conversation around one's drug and alcohol use, but also their mental health symptoms, their duration and how they are being managed. And it's a way to check in during the length of treatment to ask these questions. Using these tools can help to build capacity for clients in their own mental health literacy and in starting to name some of the things that they're experiencing. Most AOD NGOs we work with are members of the Network of Alcohol and Other Drugs Agencies, or NADA for short, which is the New South Wales AOD peak body, and they utilise the NADA-based outcome measures, many of which identify current mental health, such as the K10, the DAS, and other measures used include the ATOP, or the Quality of Life and Severity of Dependence measure. This is at a standard practice level, exemplifying that AOD services can identify mental health needs in their clients using these tools. And for mental health services funded by CESPIN, the K10 is also used, along with other optional outcome measures such as the Quality of Life and the DAS. However, currently AOD measures aren't reported against at the PHN. And this is really an opportunity for services to ensure that their intake and screening processes are comprehensive and can help to identify AOD use and other support needs in their clients that they're seeing. The ACON Substance Support Service have noted that there's been a noticeable increase in the complexity of presenting issues for clients, including complex trauma, domestic violence, childhood neglect or other trauma, and severe mental health disorders, such as dissociative identity disorder, bipolar disorder, as well as borderline personality disorder, along with depression and anxiety and drug-induced psychosis. And these are often complicated by poverty, homelessness or other housing issues, as well as physical disabilities. ACON are in a good position to provide wraparound support for clients, as they're able to link in with their care coordination team, and they have a mental health peer worker that can also provide additional support. Similarly, Flourish Australia's Connect and Thrive program offers psychosocial support to people with severe mental illness who aren't receiving supports through the NDIS, through individual and group capacity building in areas such as social skills, friendships, managing daily needs, finding and maintaining a home, as well as managing substance use issues. Within this mental health program, Connect and Thrive can work with clients to connect them to local drug and alcohol units, smart recovery groups, or residential rehabilitation, for example. And the program's made a concerted effort to develop and maintain relationships with AOD providers, build an internal directory of services, and build capacity in the area of drug and alcohol for their staff. But these are just two examples of local services in our region. There are many more, and I haven't gone into too much detail here, but you'll be hearing more from Dylan at Weave and Kate at the Medically Supervised Injecting Centre at King's Cross today. Look, thanks so much for your time. Feel free to reach out to me if you have any questions at all. Thanks once again. Bye.
Hello, and thank you for your time today. My name is Kate and I work as the Mental Health Nurse Coordinator at the Uniting Medically Supervised Injecting Centre. Before working at the Injecting Centre, I've worked in drug and alcohol services, assertive outreach settings and acute adult mental health settings. And really it's through these experiences that I've become an advocate for trauma-informed, person-centred and holistic treatment in mental health and AOD care. I also believe that everybody has the right to access healthcare which is adapted to meet their needs. So just a brief history of MSIC. So the first official supervised injecting facility in the world began in Switzerland in 1986. The Uniting Medically Supervised Injecting Centre has been operating in King's Cross since May 2001. And for 17 years, this was the only supervised injecting facility in Australia until North Richmond in Melbourne opened a facility in 2018. So as of 2019, there are more than 120 supervised injecting facilities around the world in Switzerland, Germany, Spain, the Netherlands, and amongst others. More are being planned in places like Ireland and Scotland. So they all have the same goal, really, which is to improve public health and public amenity by reducing drug use in public spaces. They're often established in areas where there's a high concentration of people injecting drugs in view of others. And the centres vary dependent on what's happening in the local area. So some may offer smoking or intranasal drug use spaces, whereas others are only for injecting drug use. The skills and qualifications of staff vary from site to site, but generally they all have shared common goals, which are to improve health and well-being of the visitors, to reduce the number of deaths from overdose, and to reduce public drug use. So at Uniting MSIC, registered nurses and health education officers supervise injecting drug use. If there's an overdose or another health issue, we provide immediate access to emergency medical care. And our team members are also there to connect with clients and offer referrals to a variety of health and welfare services. So open since 2001, the MSIC has approximately 17,500 registered clients. Typically clients are male, in their mid-40s, and commenced injecting drug use in their teenage years. 17% of MSIC's clients identify as Aboriginal or Torres Strait Islander, and the most frequently injected drugs are heroin, followed by methamphetamine, although we did observe changes during the pandemic where methamphetamine was the most commonly injected drug at the service. So in 2017, a client census was undertaken, which found that clients had utilised the service on average for 9 years. Housing instability was common, with 40% reporting homelessness. Unemployment levels were high, as were experience of poor physical and mental health. There was also a study conducted to investigate the mental health of the 50 most frequently presenting people at the injecting centre, and this found similar experiences, really, that 62% reported homelessness, 72% reported that they'd been to jail, and 82% reported that they'd been diagnosed with a mental health condition at some point in their lives, with the most common being mood disorders, depression and anxiety. Interestingly, 96% reported having experienced a traumatic event, but only 12% had had a diagnosis of PTSD. And only 25% reported that they were currently receiving mental health support and treatment. And we know that there's a relationship between social determinants of health, mental health, and substance use. So the elevated prevalence of mental health disorders among the group isn't surprising. There was also high levels of social isolation, and we also know that this lack of social connectedness impacts on mental health. So really, MSIC is a great place to connect with people and offer support to people using a low threshold and client-centered approach. So one of the benefits of low threshold services is their ability to meet people where they're at. So this means providing a low barrier to accessing care and support. It also means working with people in a flexible and consumer-focused way. And it also means that staff accept that they don't need to change anything about the individuals accessing the service. And I think sometimes this can be hard for clinicians to move away from this fixing and problem-solving mode. It's hard to do, but it's essential to effective engagement and gaining trust. So really the first step needs to be authentic, humanistic engagement and patience, because the risk of attempting to be overly proactive and provide support and problem solving before somebody's given you that invitation is it inadvertently reinforces stigma and can create additional barriers to care for the person. So the harm reduction principles are well aligned to the guiding principles outlined in the comorbidity guidelines and are essential to the basis of trusted working relationships. So how did we put the principles into practice at MSIC? So this is Ben's story. We've changed his name and some aspects of his experience to protect his confidentiality. But he's a man in his mid-40s who we first met at MSIC around 15 years ago. He has a long history of public injecting and homelessness dating back to his teenage years. When he first presented to the service, he struggled to follow rules, his frustration tolerance was low, and he could quickly become emotionally dysregulated and loud, sometimes hostile and threatening. Managing behaviour on site was often pretty challenging, and he was regularly timed out from the service for his safety and the safety of others. So unsurprisingly, this behaviour was often seen by other services and called manipulative and antisocial. So despite these challenges and in situations where many other services have closed their doors to Ben, we continue to work with him. So rather than banning Ben from the service, M6 staff were encouraged to remember his challenging behaviours were a symptom of other things and not a conscious decision to be difficult. We did what we could to ensure that MSIC remained a safe space and welcoming place. And this was often hard, but we worked collaboratively to develop a behaviour support plan that was flexible, provided consistency, recognised his needs while ensuring that MSIC remained a safe and supportive space for everybody that needed to use it. So the support plan did require frequent adjustments and often resulted in Ben being timed out for short periods or having visiting hours restricted slightly. So while this was initially quite frustrating for everyone, over time, Ben learned that the support plan was there to keep him safe. And he also came to understand where MSIC could support to be flexible and where it couldn't. Ben was included in the support planning process and any changes were discussed with him and explained on returning to the service. And we at MSIC learnt that Ben's passion for Aussie rules, footy and love of the Geelong Football Club was our secret weapon. So we could use this as a safe and effective way to engage and build rapport. So MSIC staff learnt to either praise Geelong when they won a match or chide the opposing winning team if they lost. And this became a good way to either de-escalate or foster a therapeutic engagement with Ben. It took a number of years and many conversations about footy for Ben to feel safe enough to start opening up. So he was able to express to us that he had never had a sense of belonging or feeling accepted anywhere. We heard about his background, how he survived a childhood of long-term sexual abuse, as well as severe physical and psychological abuse and neglect from his primary caregivers. Maternal alcohol consumption meant that Ben has fetal alcohol spectrum disorder, as well as a profound attachment disorder. Actually, knowing this made it much easier to understand why Ben has a long history of poor relationships, poor impulse control, PTSD, dependence to opioids, and difficulty in both expressing and regulating his emotions. His struggles to get his needs met, however, meant that he had been arrested and incarcerated multiple times and in different states across Australia. So these challenges have compounded his social disadvantage, and Ben has never had stable accommodation nor treatment for his mental health or behavioural support to help modify his more challenging behaviour. So the MSIC mental health coordinator and the MSIC drug treatment referral coordinator increasingly work with Ben to access and coordinate mental health care, housing support and drug treatment. And this meant that there was lots of time spent communicating with local mental health services, attending complex care, planning meetings, liaising with hospital PEC units, inpatient and community mental health services, opioid treatment services, crisis accommodation providers and primary healthcare services. Ben's complex needs combined with homelessness often meant that admissions to hospital were crisis driven and often really short in duration. So in his loud demands for drugs and kind of fierce demeanour and opposition to rules resulted in him being barred from a lot of crisis housing services and drug treatment services. He'd been labelled by many services as antisocial and kind of treatment resistant. Presentations to those services usually resulted in code blacks being made or police having to attend the service. During this time, desperate and without his needs being met, he made veiled attempts also to injure staff if they refused to prescribe him opioids. So police were called for safety reasons, but interestingly, they also felt that Ben's needs were needs for mental health and AOD treatment, and he was taken to an emergency department. Because Ben had attracted a personality disorder diagnosis, he was often discharged without coordinated drug and alcohol or mental health treatment. At that time, we were unsuccessful in our attempts to advocate for longer admissions, and at one period we lost contact and presumed that Ben was in jail. However, a few weeks later, Ben returned to the service and told us that he'd actually had involuntary mental health treatment at a mental health unit in Greater Sydney. Significant improvements in his ability to regulate his emotions, his behaviour, and he actually really wanted to interact with his care plan. So with Ben's consent, we contacted the mental health unit for more information. We learned that Ben had been diagnosed with schizophrenia, antipsychotic medication, and opioid agonist treatment had been started. And the impression of the providers at the external health service tallied with our own observations that Ben was showing marked improvements in his mood, thinking, and behaviour, and actually he was no longer craving illicit opioids. So unfortunately, and this is quite common, there was a lack of discharge planning, and as many patients do, Ben left with no organised community treatment plan. He became homeless again, and things started to unravel a little bit. So the MSIC mental health nurse, which is me, and the referral coordinator spent considerable time arranging referrals to opioid treatment services, arranged for transfer of the medical prescription to be sent by the inpatient unit to the specialist prescribing service, and facilitated referral and handover of care, and went with Ben to the initial appointment. Ben was also referred to a local mental health outreach service who, with Ben's and the service agreement, agreed to meet him on site at MSIC, and they were able to recommence his mental health medications and to begin to coordinate the other health and social welfare needs. So within days of hospital discharge, despite no planning, Ben had received his second injection of depo-buprenorphine, and his antipsychotic medication had been continued. We were able over the next 3 months to treat Ben's hepatitis C, which was diagnosed via an on-site dry blood spot test, and his treatment was arranged and managed through the primary health service that were providing satellite clinics on site. So, and he cleared the virus. So appropriate housing and advocacy referrals were made, which meant there was an expedited housing application. We remained a service where Ben felt most connected to. So at his request, we had multi-agency meetings. And in early 2001, Ben was finally housed close to his support networks with a furniture package. So the change in Ben actually has been profound. He can articulate what his needs are. He can actively contribute to the planning of his care, and he's better able to sit with discomfort when he feels his needs are not being met. And his extraordinarily resilience is apparent. And throughout all of this, his passion for his beloved Geelong team never wavered. And we're thankful and proud that for the first time in his life, he now has his own television and a safe and secure place to watch a match. So thank you for your time. And if you have any further questions, please do reach out. Thank you.
Hi everyone, my name is Dylan and I'm the Program Manager for the Speak Out Dual Diagnosis Program at Weave Youth and Community Services. I'm speaking today on the unceded Gadigal land of the Eora Nation, and before I continue, I'd like to acknowledge that we live and work every day in this country on Aboriginal land, and that sovereignty was never ceded. It always was and always will be Aboriginal land. I'm very grateful for the opportunity to be speaking today about how AOD services are providing care for people with co-occurring alcohol and drug use and mental health needs as part of this webinar on the comorbidity guidelines. me working in a service that delivers wraparound supports to people presenting with co-occurring mental health experiences and AOD use, I'll be focusing today on talking about the importance of working holistically and being person-led by considering the context, goals, and needs of a person. I'll also be talking about working collaboratively across services and involving additional support as a person's needs are identified. At Weave, we predominantly work in supporting young people. So to a point, some of what I will discuss will be youth specific. In the case where these concepts may not function as well in your context, for example, you support older people or much longer term drug use, then the principles of your practice and your experience in supporting those people may be slightly different. However, I would like to think that most of this is fairly transferable, and I hope that you're able to take something away from this today. Much of the service delivery for people presenting with co-occurring AOD use and mental health experiences remains separate and distinct. Much of the clinical evidence available, including in the comorbidity guidelines, is highlighting that integrated treatments offer the best methods for engaging and retaining clients with both AOD use and mental health support needs. Back in 2019, in a submission to the Victorian Royal Commission into Mental Health, the Victorian Dual Diagnosis Institute noted that, quote, "These people with co-occurring mental health and drug and alcohol challenges are the people who tend to have poorer outcomes and higher costs of care. However, instead of systems being designed to clearly welcome and prioritize them, individuals and families with complexity have historically been experienced as misfits at every level." Moreover, research published in the Journal of Substance Abuse Treatment lists that approximately 55% of people experiencing AOD use disorder also experience a co-occurring mental health condition. And similarly, they list that up to 60% of people experiencing a mental health condition also have or have lived with substance dependency. Now, I say this a lot, and if you've heard me talk before, then I am sorry in advance. But I honestly believe that if you're working in AOD, then you are working in mental health and vice versa. Sometimes that simple clarification is useful in repositioning how we approach different situations, knowing that more often than not, we will be working with people with co-occurring issues. And also more often than not, we're still able to do our work and we're still able to do good work with these people. Firstly, I would like to say that it is not an impossible task to support somebody with co-occurring mental health and alcohol and drug use. It definitely is possible to have a significant impact in supporting either or both mental health experiences or AOD use while both are actively presenting issues for an individual. When working with co-occurring mental health and alcohol and drug use, it's important for me to try to not replicate the compartmentalization or the stratification of services that many people have experienced in attempting to receive care and support. Often, I have heard from clients that they have been told along the way that they were too unwell for AOD services or they're using too much for mental health supports. Now, we have an opportunity to break up that common practice. We have an opportunity to take the moments that are presented to us to have an impact when somebody is stating that they want support. It's not every day that somebody feels like they are in a place to put themselves in that uncomfortable position, that position that requires so much vulnerability and requires you to trust a perfect stranger with such deeply personal and private information, whether that's experiences of trauma, history of drug use, family connections, whatever that may be. That's why when those opportunities do present, we should always do what we can to support that person, rather than see the complexities of their comorbidity as some insurmountable barrier. Our program, Speak Out, here at Weave, recently underwent an external evaluation, and I'm reminded of one of the quotes that came out of the client feedback portion. This person stated, quote, "Not a lot of places will treat you if you're a drug user with mental health problems. They're just like, lost cause, that one, you know," end quote. I have it up on screen actually as well, there you can see. I honestly think that's such a simple and great way to sum it up. We don't want to replicate that feeling for people, and we want to try to break that pattern and see somebody as a person, not just as their problems, as their behaviors, as their presenting issues. I also want to talk a little bit about the importance of that person-led approach and in trusting an individual's expertise in their own experience and understanding of their needs and their goals. Now, I'm using person-led language here, but in the comorbidity guidelines, you'll find fantastic information about how to be client-centered, which is reflective of a lot of what I'll discuss. Now, for me, being person-led is about hearing from the person and responding to what it is that they identify themselves as the most significant presenting issue or issues. If someone, and this is a simple example, is presenting with AOD use issues, but themselves are more concerned with their long-term homelessness, and beyond that, identify this homelessness as the significant barrier to addressing the AOD use, then the person-led and responsive approach would be to support that person through their homelessness, or to engage a service that can support them in that way. Although working through the presenting issues may happen in an order that seems less predictable or maybe less sensible at times to us as workers, truly, for me, the best and most effective breakthroughs are when both people in the support relationship, so that's you and your client, are equally motivated and inspired by the approach and the direction. If someone has placed their trust in you and shared that vulnerability and shared their issues, I feel it's only logical for them to expect of you or of us as professionals the trust to believe in their understanding of what it is that is important to them and how they want to be supported. Maybe some more complex examples. For instance, when a person is presenting with urgent needs, whether they be physical health concerns, suicide attempts, overdose, whatever that might be. The same approach of hearing from a person and then really listening to the answer of what they need can still be true. When living with co-occurring mental health and AOD use, the two can be so often deeply intertwined that in those moments of crisis, it is not possible to disentangle them and then compartmentalize the type of support that a person should be receiving. That they should be receiving AOD assistance before their mental health support, or they should be receiving mental health supports before their AOD assistance. Hearing from a person and being led by them is often the safest and most appropriate response, even in those complex situations. It allows you to hear from the person how to disentangle those supports that we can offer. They do the work for us if we really tune in. To be clear, it's not just about listening to somebody and then doing whatever it is that they say. It's about respecting the wisdom of the individual and hearing from them what it is that they need and how they need to be engaged. Then rely on your skills, your training, your context, your role, your colleagues, your instincts to respond appropriately and effectively with that information. I don't see it as our job to tell someone else what they need to do for themselves or how they need to be. Someone can be themselves and lead the conversation around what they need, with us as workers still having the ability to have profound impacts. In fact, many people have not had the opportunity to have those kinds of support relationships, those relationships that center them and center their knowledge and appreciate the insight and unparalleled expertise that a person can have in themselves and what they require to be well. The comorbidity guidelines talk about working holistically, and the guidelines contain good information around this. But I would like to acknowledge that sometimes in a service that is tasked with working with particular criteria or with delivering a particular service, this can be difficult, as there's likely going to be things that you as a worker will be required to provide to a person or provide in a particular way. I believe that there will always be scope to remain person-led, however, and responsive, whilst also meeting your professional obligations. It could be as basic as making a warm referral to another service to ensure that person receives the support they need, or it's about delivering the function of your role in a way that respects an individual's wisdom and respects their autonomy. People are so often disempowered by other people identifying for them what is important to them, or telling them how to be, how to feel, how to drink, how much to drink, how to use, how much to use, don't use, and so on. I'm always trying to find opportunities to run counter to those experiences, to listen to and to connect and collaborate with a person on what they would see as improvements to their alcohol and drug use or to their mental health, as what they would find helpful in impacting their well-being. Even in a context where abstinence is required to deliver support, there are still ways to hear from a person, what is it that you are identifying for me that you really require in this moment? Again, it's not just blindly listening and acting on whatever it is that someone's telling you to do. But if somebody is bringing you these broad issues, then in our capacity as workers in this sector, we can assist in breaking the issues down into smaller, more tangible and achievable goals. So the support needs and the presenting issues don't feel so enormous for both practitioner and client. Similarly, I believe that understanding that why behind what a person sees as the big issues is a real opportunity to gain some insight into the context and the goals of the person. It's going to naturally present an opportunity to connect with this person and to center them in their own support journey and open avenues for you to build rapport and trust with the person. I'm thinking in those moments, what is the context of this person presenting here, and how will we be able to engage them and meaningfully support them? Again, it's an incredibly daunting task to ask for help, to trust a perfect stranger with your story and with your well-being. So when we're doing the work, I'm aiming to be as non-judgmental as I can be, as open-minded as I can be, to see the opportunities to connect and the opportunities to create some middle ground between myself and the person that I'm supporting, and doing what I can along the way to remove any of the client expert type relationships. Now, within an AOD support context, the comorbidity guidelines make reference to a number of services that an AOD worker may need to engage in caring for their client, including, but not limited to, housing services, support for justice system involvement, and social services, including financial supports like Centrelink. In Speak Out, here at Weave Youth and Community Services, we are somewhat uniquely positioned to work across and support in a number of these areas, as we run a long-term program model that doesn't have the time pressures of a short-term intervention. We provide wraparound care that works holistically and supports the client through a wide range of experiences and issues by providing therapeutic casework, counselling, art therapy, creative projects, groups, and more. I understand that not all services will have integrated or multidisciplinary teams, so it is important to begin building strong relationships and knowledge of all the options available to you to holistically support your clients. Try to focus on the professional relationships and referral pathways that supplement your practice and assist you to provide the best possible care to your clients. For example, practically, if you are a mental health service that cannot work with active AOD use, potentially a good starting place is connecting with an AOD service that can provide the types of supports that you are unable to provide to somebody with co-occurring issues. And even though, as I described, our team works within an integrated holistic service, we still very much rely upon those common and well understood referral pathways to ensure that the people that we support are able to access the kinds of support and services that they need to support their well-being. It has been a little bit short, it feels, given the time that we have for today's webinar, but I hope that I've been able to describe some useful concepts in providing supports to people with co-occurring mental health experiences and alcohol and other drug use. If any of what I've said is of interest, or you'd like to unpack it in some more detail, or connect to discuss any of today's content or otherwise, then I'm really happy for you to reach out and we can connect in the future. I appreciate very much the opportunity to share my thoughts with you today. And I'd like to say thank you to the Matilda Centre for organising today's event. I encourage you all to engage with the fantastic resources that the Matilda Centre provides, and particularly to engage with the comorbidity guidelines, which contain so much rich and detailed information on how to provide best practice support to those that we are working with experiencing co-occurring mental health and AOD. Thank you again, and goodbye.
Thank you so much, Esther, Kate and Dylan. That was fantastic. We have had some amazing insights and questions coming through during your presentations through the chat and the Q&A, and I can see that from what most of everybody's been writing, everybody is pretty much approaching this the same way. They've been sharing some common frustrations, and we may not actually get through all of the questions that have come through, and in which case we will post some responses to those on our website with the slides and the recording a little bit later for you to access, but we will start going through them now. Also, just from a personal perspective, it has been really exciting and rewarding to have worked with CESPN and also Weave and MSIC for the past few years in the comorbidity space, and CESPN especially see how you have supported organisational change and implementation at the workforce and service level. So some of the questions, actually, I'm going to get us started with probably a question for Kate. Is Kate, are you back, Kate? Yeah, cool. Just wanted to say the case study that you described that people have also commented on, you gave an example of someone who had quite a complex presentation. Is that complexity that Ben presented with quite typical of people who are accessing MSIC?
Yeah, it is often, and often people experiencing service restrictions as a result of the complexity. And usually it's on a background of trauma, to be honest. Yeah.
And this is probably a question for you and Dylan, actually. Is there any advice you would give to services or workers on how they can take more of an assertive outreach or advocacy role on behalf of their clients?
I think, sorry, Dylan, please jump in as well. What we do is we often go and do like coffee meet and greets with services, just to introduce ourselves, explain what the service does, how can we work together to smooth and shorten handover processes and referral processes. Advocacy, we do a lot of inviting services into, people can come and do site visits so they understand our service better and what we do. And I think advocacy, you just have to keep trying. Unfortunately, it's tricky, but you just keep trying, and sometimes something works, if that makes sense.
Yeah, it sounds like a lot of, I suppose once you've been doing it for a while, I imagine you would have some personal connections and build up those relationships that you can come back to and build up that network after a little while. Esther, one of the recommendations that came out of the scoping review you mentioned was for placements. So for alcohol and other drug workers to have a placement in mental health services and vice versa. So this is probably a question for all of you, I suppose, approaching placements from different perspectives. What do you think about how these might work in practice, and if there were any challenges to putting them in place?
It's a really good, I think it's a great idea. I know that a sort of reciprocal rotations project ran down in Victoria, actually, as a bit of a trial. And there were some pros and cons to this kind of model. I think from my perspective, or the CESPN perspective, it'd be great to sort of start something small. There was an idea around a sort of coffee catch-ups idea where mental health and drug and alcohol workers could, you know, meet up for a coffee. This is something also that's came out of Victoria. Thank you, Vic. But it's just an idea that it's sort of a pretty open conversation just to build relationships between the two sectors, get to know your local workforce, and come back to your teams with some learnings and maybe, you know, some new information about who to contact in your local area if you are working with a client who has co-occurring needs. Yes, Gary said randomized coffee trial.
Yeah, I saw that as well.
Gary, exactly.
We'll put that in for funding, Gary.
Yeah.
And another one for you, Esther. Are there any other initiatives that CESPN sees as priorities moving forward for supporting the workforce or service capacity to respond to mental health conditions for their clients?
Yeah, really a lot of the main priorities for supporting clients with co-occurring needs are within the mental health and AOD action plan. I think we've heard from a lot of the audience around, you know, some of the challenges, and really for us, there's an opportunity for us to discuss with peak body such as the Mental Health Coordinating Council within New South Wales, as well as the Network of Alcohol and Other Drug Agencies, NADA, around some of the issues such as the interaction between hospital and community services, but also workforce capacity building activities. So we're looking at, providing training and workforce activities for staff in different environments, such as LHDs and within NGOs, and thinking through some of the different ways that we can do that.
Mm. Yeah, and it looks like from a lot of the questions and comments that were coming through, people have been experiencing difficulty from one side of, well, either mental health or AOD services taking on new clients. So, for example, trying to get their clients into services or treatments. I don't know whether anybody has any suggestions for how to help with that, beyond keep trying.
That's a hard question.
Yeah.
Yeah, it's always very resource strapped, in this sector. And I was keeping an eye on the comments the whole way through as well in the chat, and I appreciate everybody jumping in through all the presentations. But there's so many uniform experiences, like it's not a unique experience to try to find and advocate for somebody that you're supporting and not be able to find that next pathway easily, or to manage wait lists, or to manage the services. So I think if anything, it's really doing what you can in your capacity whilst people are on wait lists and are in that kind of liminal space. Remain optimistic, build connections, and see where you can both best have impact.
Yeah. Do you have any suggestions for how people can start to build those connections if they're, new to the field, for example?
Oh, yeah. I mean, my tactic was always just to be a serial pest. And I would just hit everybody up, and see who was keen to yarn about something at any given moment, and sort of be willing to connect. And I really believe that both sectors, if we talk about them as two distinct areas of healthcare and AOD and mental health, have so much to learn from each other. There's deep wisdom in service delivery in both, so just going in curiously and wanting to connect with clinicians or community workers or whoever it might be, peer workers, especially in the space, and just try to grow that network as wide as possible. And even if they don't become somebody that you can then call upon in that moment of need for the person you're supporting, some of that wisdom that they may impart to you is going to be in there somewhere, and hopefully you can draw upon that in those moments you require them. Yeah.
Yep. So I am aware that there are questions we haven't gotten to, and we'll pass these on and post them on our website. But just before we end, we are running out of time, wanted to quickly put up links to the resources that were mentioned, and of course the what is funding this series. So the National Comorbidity Guidelines and our website, where you can access these resources. And wanted to quickly thank you everybody for joining us for this webinar. And if you are interested in viewing this recording, registering for our next webinar, or having a look at the library of resources and webinars, you can do this at the website there. And just to mention that our next webinar is going to be on the 29th of April, and that is going to be focusing on treating co-occurring substance use and mental health disorders using tools from CBT. But until then, just wanted to thank you all for joining us today, and a huge thank you again to Esther, Kate and Dylan. And please enjoy the rest of your day, and see you all soon. Thank you again.